All right. Good morning, ladies and gentlemen. Good morning, Luzon, Visayas, and Mindanao, and NZR. Welcome to the second webinar series of the Metro Manila Health Research and Development Consortium, or MMHRDC, or PCHRD, to this fourth International Symposium and 11th Annual Scientific Conference with a theme, Road to SuperSeniors, the Science of Aging. Is earlier than you think, but it is never too late. Last week, as of today, we have an equally distinguished speakers to discuss very interesting paper relating to our conference theme. Before we go to our program proper, may I ask you to direct your attention to the screen as I introduce the agencies responsible to this important webinar. Okay, we have the Far Eastern University, Our Lady of Fatima University, the PCHRD, DOST, University of the Philippines, Manila, CHED, the DOH, and the MMHRDC. All right? So those are the people who have worked for this webinar. For a smooth flow of our webinar, kindly take notes of the following. Questions and answers will be after each speaker's presentation. Hence, your question can be posted at the chat box provided at the bottom of your screen. Since we have FB Live, you can also send your question there. Post-test and evaluation link will be flashed at the end, so please accomplish this Google form. Issuance of the participation will be issued in your respective emails. And for those asking for CPD, you can do it by self-directed at PRC. Okay? To formally welcome us and signal the starts of this program, may we call our chair of the MMHRDC Steering Committee and currently the Executive Director of the National Institute of Health, UP Manila, Dr. Eva Cuchanco de la Paz, for her welcoming remarks. Ma'am?
DOST Philippine Council for Health Research and Development Executive Director Dr. Jaime Montoya, Commission on Higher Education Commissioner Dr. Lilian de las Llagas, our distinguished keynote speaker, UP Manila Chancellor and MMHRDC Lead Convener Dr. Carmencita Padilla, DOST NCR Director and Lead Convener Engineer Jose Patalinhog III, DOH MMHRDC Director Dr. Corazon Flores, esteemed speakers, colleagues from various government agencies, representatives from the current member institutions of MMHRDC, and the Regional Health Research and Development Consortia, friends, and to all health enthusiasts, a pleasant morning to all and welcome to the Metro Manila Health Research and Development Consortium webinar series entitled The Road to SuperSeniors, The Science of Aging. It's earlier than you think, but it's never too late. This webinar series comes at a time when the world is still grappling with the adverse and devastating impact of the COVID-19 pandemic on politics, culture, economics, and most especially on our day-to-day interaction with our colleagues, friends, and family. This pandemic has dramatically altered the dynamics of our normal lifestyle in ways we've never imagined before. As the rest of the world is racing to find a cure and solutions to the COVID-19 pandemic, our country's health system is likewise trying and steadily adapting to the new normal, thanks primarily to the country's selfless health professionals who continue to persevere in alleviating the suffering of the Filipino people across all sectors of society. But we need to strategize and find innovative ways that would build the capacity of our people in adapting and living through this new normal. In doing so, we should not forget one of our most vulnerable sectors, the elderly Filipinos. Just like us, they are also experiencing the numbing anxiety and uncertainty caused by this pandemic and even boredom. Guidelines and policies have to be crafted that can help them cope with the pandemic and empower them to be valued members of society, remaining productive for their families and communities, and doing what they want to do are the hallmarks of healthy aging. Maintaining one's health while undergoing the aging process requires not only to focus on individuals, but also to create an environment which allows them to do what they want to do. The webinar is really timely and relevant. This webinar will allow us to navigate new and fresh perspectives on how we should approach and view the aging process. The series will run through 3 Saturdays for the month of September, starting today, September 12. It will provide us an avenue to learn from internationally and nationally recognized experts on how we should prepare ourselves and our loved ones on the path of becoming super seniors, and how we could empower the Filipino elderly when it comes to their rights and privileges. This webinar series also provides a suitable platform where we could exchange and share ideas to facilitate the realization of our ultimate goal, a Filipino society of empowered seniors. Before I end, I would like to express my deepest gratitude to the Far Eastern University, led by Dr. Michael Alba, and Our Lady of Fatima University, led by Dr. Carolyn Marian Enriquez, who co-organized this webinar together with all the officials and staff of MMHRDC, headed by Dr. Hilton Lam, the Director of the Institute of Health Policy and Development Studies, National Institutes of Health, UP Manila. Thank you for making this important event a reality. I would also like to extend my sincerest appreciation to PCHRD and CHED, our most valued partners in health research and development. To all the participants, please fasten your seatbelt and enjoy the ride as we navigate the exciting landscape of the aging process and the road to a society of super seniors. Magandang umaga po sa ating lahat.
All right. Thank you very much, Dr. De La Paz, for that welcome remarks and indicating to us the objectives of this webinar. So we have now 303 on Zoom, and I think it's increasing. So now let us listen to the messages from our distinguished head of organizing agencies. First in line, we will listen to the lead convener of the MMHRDC and the Chancellor of the UP Manila for the Gorgios Carmencita Di Padilla. This will be followed by the message from the DOST, Director of the National Capital Region, Engineer Jose Patalinhug III. Likewise, we will listen to the message of the Director of the Metro Manila Health Department of the Department of Health, Dr. Corazon Flores. And we will also listen for a message coming from the Director of the CHED NCR, Dr. Virginia Aquiate. And finally, from the mother of the MMHRDC, our Executive Director for the Philippine Council for Health Research and Development, Dr. C. Montoya. So, ladies and gentlemen, let's listen to their messages.
Good day to all participants, speakers, organizers, and guests. In behalf of the member institutions and as Metro Manila Health Research Development Consortium lead convener, I welcome you to the virtual edition of the MMHRDC International Symposium and 11th Annual Scientific Conference being hosted by the Far Eastern University. I commend the MMHRDC for pushing through with this symposium earlier slated for May 28 to 29 this year, but sidelined by the pandemic. The postponement enabled more participants from here and abroad, giving way to increased interaction for exchange of knowledge and experiences. Amidst this pandemic, the consortium is committed to continue its role in disseminating relevant researches to the science community through this webinar series. The theme, The Road to Super Seniors, the Science of Aging, it's earlier than you think, but it's never too late, is relevant and urgent as it is timely and auspicious. 10 speakers on a wide range of topics and about 500 participants from different countries, institutions, and disciplines is quite a harvest of ideas and inputs that will benefit plans and programs for the aging sector. As the population of the Philippines and the rest of the world continues to age, there is a need to align our health and social systems to this demographic shift. The World Health Organization projects that by 2020, the number of people aged 60 years and older will outnumber children younger than 5 years old. By 2050, 80% of older people will be living in low and middle income countries, while the proportion of the world's people aged 60 years and older will almost double from 12% in 2015 to 22%. The Philippines is about to experience this increase in its aging population. We know that aging is an inevitable and challenging process, so we have to recognize its demands and prepare adequately. Let us reverse the notion that older persons are a burden. Rather, healthy older persons can still fulfill important roles in society. The World Health Organization Global Strategy and Action Plan on Aging and Health acknowledges that many older people will experience very significant losses, whether of physical or cognitive capacity, or of family, friends, and the roles they played earlier in life. Societal responses to aging should not deny these difficulties, but seek to foster recovery, adaptation, and dignity. This will require transformative approaches that recognize the rights of older people and enable them to thrive in the complex, changing, and unpredictable environment they are likely to live in now and in the future. These approaches must foster the ability of older people to make multiple contributions in an environment that respects their dignity and human rights, free from gender and age-based discrimination. Maintaining optimal health while aging is not easy. With an already burdened health system, addressing the needs and conditions of this sector is extremely challenging. The COVID-19 pandemic has brought out further vulnerabilities of the aged and aging persons. Research is an effective way by which the academe can commit to the global strategy and action plan on aging that focuses on developing age-friendly environments and providing measurements and monitoring. UP Manila, as the country's health sciences center, has research such as this at its core. We therefore welcome this webinar series as an encouraging stride to highlight the researches and collaboration done on this theme. The knowledge and information generated will assist policymakers and government leaders in planning for additional services as a result of expected growth in the number of older persons. We cannot have it any other way. The time is now to focus on the health needs and challenges of the aging sector. The time is now to plan for health programs and services in our goal of envisioning a future where aging persons can still be healthy and productive contributors to society. I pray that you will have the most fruitful discussion and sharing in all of the sessions. A pleasant good morning to all.
We extend our warmest congratulations to the Metro Manila Health Research and Development Consortium for this webinar series on the road to SuperSeniors, the science of aging. We commend the members of the MMHRDC for studies that tackle productive aging. This webinar series serves as a tribute to the prime years of the aging population, telling us that it is early that you think, but it's never too late. The series will discuss science-based approaches on the different aspects of growing older in age. There is a continuing need to focus the lenses of research and development to vulnerable groups such as the aging population. We urge our researchers to consider the patterns of change and transition that the elderly goes through as they age. Likewise, we urge our policymakers to integrate R&D outputs and crafting frameworks and plans in improving the elderly's common cognitive and physical health. Most importantly, provide quality healthcare while reducing healthcare costs. May we also share that DOST-NCR has senior citizen groups provided with assistance for livelihood productivity. Aside from doing R&D, we can also transfer science-based knowledge, products, by collaborating with local government units and non-government organizations. We are one with you in focusing SFT efforts to benefit the elderly. Again, our warmest congratulations.
Magandang araw po sa ating lahat, sa ating pong organizer ng webinar series na to, sa ating pong mga participants. Sana po'y nasa mabuti kayong kalagayan at wala namang iniindang anumang karamdaman. Ngayon po, araw na to, nagkakaroon tayong tinatawag na webinar series, The Road to SuperSeniors, The Science of Aging. It is earlier than you think, but it is never too late. SuperSeniors. Ano po bang ibig sabihin natin ito? Ito po yung tinatawag nating lahat tayong nagnanais naman na mas humaba pa ang buhay. The super seniors are those beyond 80 years old. At tayo, alam ko naman po, nalulungkot tayo pagka na may nabalitaan tayo na may mga wala pang 30, wala pang 40 na matay na po, inatake. And ngayong pong araw na to, tayong lahat ay may matututunan. Marami po tayong matutunan sa tinatawag nating webinar series na to. And we at the Department of Health, Metro Manila Center for Health Development are one with the Metro Manila Health Research Development Consortium with their vision of addressing issues such as this towards the achievement of health goals that are of local, national, and international significance. This time, we are addressing a battle against time, against faded youth, and things there in between. We're battling that time kung saan po mas gusto po nating mas humaba pa ang buhay ng bawat isa. At present, of course, alam naman nating lahat, we're battling against COVID-19. We are battling against epidemic, napakadalas po yan. Last year, meron tayong mga tinawag na measles, leptospirosis, polio. But of course, the battle against aging. Kumbaga, pagka nakarits na, lalo na sa mga babae, pagka nakarits na ng 40s, nagkakaroon na lang mga depression o nalulungkot na siya dahil lalo na pagka may mga kulubot na. Alam niyo naman po, sa ating mga kabaihan na balidoso, gusto po natin ma-preserve ang ating kagandahan. I'm glad, of course we're glad, that it's never too late for us to tackle this topic. And I alam ko po, you as our participants, your presence in this webinar is an indicator of your interest to do much for this aging problem that we are facing now. And of course, alam po natin lahat, tayong lahat tatanda rin. And what we are learning here will be of great help, not only for us, but for our families and loved ones. Kaya po, tayo po lahat ay makinig ng mabuti dito po sa webinar series na to. With a variety of topics offered in this webinar, with so much anticipation, I am thrilled that the insights from our resource speakers will further concretize our very foundation and be instrumental in expanding our rates of influence. Allow me to express my early congratulations to the Metro Manila Research and Development Team. Of course, maraming salamat din po sa ating pong mga partners, co-organizing institution, Far Eastern University, and of course, Our Lady of Fatima University for such a brilliant idea of putting this into action. This is a worthwhile experience for all of us to continuously learn something new on how we can further grow to improve or what we can do further to have a longer life for everyone. And of course, it's my wish that the road to SuperSeniors be galvanized into action in Metro Manila, if not for the whole archipelago. A simple tip that we have to put into our mind to live a longer and of course satisfied life. Take time, of course, to pray, to meditate, to give thanks to what we have received, to exercise, to have a good diet. And lastly, my prayer for everyone is taken from Psalms 91 verse 16. I pray that all of us will experience a long and satisfied life. Magandang araw po sa ating lahat.
to the organizers of the Metro Manila Health Research and Development Consortium, its officers, its members, the participating higher education institutions, especially the Far Eastern University and the Our Lady of Fatima University, who are sponsoring this series of webinars. Distinguished guests, ladies and gentlemen, good morning to one and all. Your theme for today, the road to SuperSeniors, the science of aging, is a very appropriate one. It's earlier than you think, but it's never too late. It is very timely in these times when the senior populace is suddenly increasing. It is also for this reason that we, from the Commission on Higher Education, National Capital Region, endorsed on September 1, 2020, this series of webinars, especially to our higher education institutions who have graduate schools, because most of the professors there are seniors. Talking about seniors and seniority, I still remember the time when I was on an air-conditioned bus bound to Baguio. Because I was a chance passenger, I did not get my ticket yet. I happened to be seated to a senior lady who also just entered, and she too is a chance passenger. After a few minutes, the conductor of the bus came near and asked the senior lady, "Are you a senior?" To my surprise, this lady suddenly got angry and strongly retorted, "Bakit? Mukhang matanda ba ako?" And looking at the very bewildered poor conductor, I proudly approached him and I said, "I am a senior." The conductor then showed me to a very nice seat in front and even gave me a 20% discount. The senior lady retorted again, and she said, "Hindi naman hamak na mas matanda ako sa kanya. Bakit mo pa siya dinala doon sa mas magandang upuan, habang ako naman andito?" I looked at her humbly and I said, "Here is my ID. I am a senior." Whether, my dear friends, whether we are mistaken as not yet senior or already seniors, let's be proud that we have reached this stage. And let us be happy because this time we are already enjoying the perks of seniority. With the 20% discount, with the different allowances, and with, the added taxes are already being removed from us. So, it is for this reason, my dear friends, especially to the seniors, that I am happy to share to you the tips of being a productive and happy senior. I took it from the acronym Senior Aging, SENIOR. And aging, AGEING. So to start with, letter S, be spiritual. S, be spiritual. Always acknowledge that there is this Almighty Father guiding us day and night. Smile and say good things to people. Letter E, embrace the good vibes. Throw away bitterness in your life. There is no time to grudge, to pout, to be negative. In these pandemic times, let's embrace the good vibes and make things look positive. Letter M, network with other people. Do not ignore people. Network with them. And be happy. Letter I, inspire others instead of insulting them. Inspire others instead of insulting them. And letter R, remember the good times. Do not forget your past happy moments. According to some psychologists, they say that the farther you can remember your happy moments in your childhood, maybe when you are 2, you are 3 or 4 years old, the most likely that you will not be experiencing Alzheimer's or the loss of memory. So, senior. Now we come to aging. Aging. A, add spices to your life. Do Zumba, go out with friends, and be comfortable with those that you really want to go out with. Letter G, give to charity. Be compassionate to the needy. Be compassionate to the poor. Letter E, as I have said earlier, enjoy every minute as if it is your last. Enjoy every minute as if it is your last to stay on earth. Letter I again, involve others to good work. Involve others to do good work. Letter M, nurture your skills and talents and share it to others. Try doing artwork. Try embroidery. Try other things. Try to compose poetry or poems and sing a lot. Letter G, go out and serve. As seniors, we have to be doing extension work. We have to join civic organizations. We have to do volunteer work as much as we can. My dear friends, especially my dear seniors, by then and only then can we say that we are on the road for super positive-minded seniors. Ever loving, ever caring, ever inspiring to other seniors, and ever prayerful. Keep safe, my dear friends. Mabuhay tayong lahat. Mabuhay ang Metro Manila Health and Research and mabuhay ang Manila, Metro Manila Health and Research and Development Consortium. Mabuhay tayong lahat. Thank you po.
I would like to congratulate the Metro Manila Health Research and Development Consortium for the successful launch of this webinar series. As COVID-19 continues to pose a great deal of challenges towards the way we do health research, this event is proof of our commitment to bring solutions closer to our communities. The theme, The Road to Super Seniors, the Science of Aging. It's earlier than you think, but it's never too late, highlights the value of creating equitable and inclusive access to healthcare and improving the quality of life in our country for all ages. According to the Commission on Population in 2019, approximately 8.2% of Filipinos are senior citizens. As our population grows older, it is even more relevant that we work for the development of evidence-based policies and programs that will ensure better lives for our elderly. As an avenue for shared learning, we hope that this event will also boost opportunities for collaborations and network building. We hope that even more researchers will join us in our mission of providing equitable access to healthcare for our senior citizens and our communities. Allow me again to thank the Metro Manila Health Research and Development Consortium for organizing this event despite the challenges and for being our partner in pursuing health and health-related activities that are attuned to the needs of our communities. Cheers to a vibrant research community for better healthcare and for better lives. Maraming salamat po at mabuhay po tayong lahat.
Let's go to our program proper. Our first speaker is currently the director of the University of the Philippines Population Institute. Her main research interest is on the aging of the population. She has spearheaded through two large national surveys on older Filipinos and is currently the project investigator for the 2018 longitudinal study on aging and health in the Philippines, or what we call LSAHP. LSAHP is the first longitudinal study on older people in the Philippines and is part of a two-country comparative study on aging in the Philippines and Vietnam. Ladies and gentlemen, let us welcome Dr. T. Cruz as she presents COVID-19 and the Filipino older people. Dr. Grace Cruz, please.
So the title of my paper is The Filipino Older People and COVID-19. Is my screen showing? Okay, so this is the outline of my presentation. I will start with the data sources and talk a bit about the status of Filipino older people, providing evidence from the baseline data of the LSAP as introduced earlier. And I'll discuss about the vulnerability of the older Filipinos to COVID-19, and we'll end with some concluding notes. So my data sources for my presentation are the 2018 baseline data of the longitudinal study of aging and health in the Philippines, or LSAP, and the COVID-19 tracker of the Department of Health, which was compiled by the University of the Philippines Population Institute and the Demographic Research and Development Foundation, or DRDF. So the LSAP is the first nationally representative longitudinal study on aging to be conducted in the country and is aimed to investigate the health status and well-being of Filipino older people and their correlates. It also aims to assess the determinants of health status and transitions in health. So the study is nationally representative, and it has a total of about 6,000 respondents ages 60 years and over living in community dwellings. So we did not include institutional older persons. The design oversampled those who are in the older ages, 70 years and over, because the design is panel, and this will ensure that we will have enough cases when we follow up the same respondents 2 years from the time that we conducted our first interview. We're supposed to go back to the field this year, end of this year, but because of COVID, we're likely going to delay it for early next year. So the study is a multi-actor study in the sense that we did not only study the older persons, but we also interviewed their caregivers, their adult children. And it's funded by the Economic Research Institute for ASEAN and East Asia or area. The study employed 5 instruments. We have the household questionnaire to be able to know the context, the household context of the older person, the main questionnaire for the older person. We also had a separate questionnaire for the caregiver, a separate questionnaire for the adult child, and we had an anthropometric questionnaire for the older person. The reason why we took a separate questionnaire for the caregiver and the adult child is because we wanted to have additional anchors for future tracking of the older person, so that this will hopefully improve the response rate in the follow-up survey. So this is the summary of interviews conducted. As I mentioned, we had a total of 5,985 respondents, and the response rate was quite high, very impressive at 95%. And we also had an SPMSQ. This is a short, portable mental state questionnaire that aimed to measure the cognitive ability of our respondents. Results show that 5% of the sample failed the SPMSQ questionnaire, so they were not allowed to proceed with the interview. But we allowed them to have a proxy to answer the factual questions. We also had an anthropometric measurements that gathered information, including their blood pressure. We also used a peak flow meter, the hand grip strength, gait, balance, functional reach, and BMI, among others. We also used the Tanita Inner Body Composition Monitor to gather information such as the percentage of body fat, muscle mass, and among others. So who are the Filipino older people? I will first present their socio-demographic profile. And we all know that women outlive their male counterparts. So in old age, you have more older women than older men. 60% of all older persons are females as compared to 40% older males. Most of them are Roman Catholic, and most of them, about 6 out of 10, live in the rural areas. This is a generation with very high fertility, and they recorded an average of 5.7 children, or about 6 children on the average. In terms of their marital status, they're very different for males and females. If you see, the females are mostly widowed, 56% of them, whereas 70% of the male counterparts are either currently married or living in. This is because the older males are more likely to remarry. In terms of economic status, you see that 57% because the older males are more likely to remarry. In terms of economic status, you see that 57% of the males here are currently working. So there's still a lot of them who are currently working as compared to 39% for the females. In terms of their educational attainment, about 28% of them have at least some high school education. So, but we expect that the future generation of older persons in the country will have better education because of the improving educational attainment of the country in general. In terms of residential status, older Filipinos are most likely to be co-residing with their children. More so the males at 64% compared to 58% for the females. 14% are living alone and 9% are living with spouse only. This means that about a fourth of our older persons are living independently, either alone or with spouse only. But if you look further into those who said that they're living alone, they're not really functionally living alone, because most of them report that they have children or a kin who lives within the same barangay or nearby their place of residence. Older Filipinos report an active and reciprocal intergenerational exchange of resources and support between them and their children, both co-resident and non-co-resident children. The older person receives, in particular, financial and material support and visits from their children, and in turn, they provide emotional support for their children. They're also very involved in the care of grandchildren, particularly when the grandchildren's parents are working either within the country or abroad. Our results show that about 1 in 4 are involved in the partial or full care of any of their grandchildren. In terms of their economic status, our results show that older Filipinos are economically poor. At the time that we did the study based on the income reported, it seems that 46% are living below the poverty line. 47% are recipients of the 500 monthly social pension from DSWD, which we know is really targeted for the poor older persons. The poor economic status is also corroborated by the fact that 49%, or about half of them, said that they grew up in what they considered a poor family. So therefore, it's like a lifetime of poverty. 13% of older persons' households are also recipients of the 4Ps, or the conditional cash transfer, and 14% said that their household experienced hunger in the last 3 months. Older Filipinos have fragile and informal sources of economic support. Older women in particular are highly dependent on the financial transfers from their children. 26% consider remittances from children within the country as their most important source of income. And another 10% say that it is remittances from children abroad. So we see here that because of their dependence on remittances from abroad, the international scenario now with COVID is likely to affect the economic condition of our older people. So we see that a lesser proportion among them depend on earnings from work. But the story is different for the older males who consider earnings from work as their most important source of income. This also suggests that many of our older people are still currently working. Based on the evidence provided, the objective indicators of economic well-being, it is not surprising to note that a high level of older persons, about 57%, consider themselves having some unmet economic needs, because they said that they have some or considerable difficulty in meeting their household expenses. How about their health status? When we ask older Filipinos to give their self-rated health, about half of them rated their health to be average. More would rate their health poorer than average rather than better than average. So here, 28% almost said that they're somewhat unhealthy, and 2.7% said they're very unhealthy, as compared to 12% who said they're healthier than average, and about 1 in 10 said they're very healthy. But you see here that there's a significant difference with the females, more females who would rate their health to be very healthy compared to about 7.6 for their male counterparts. This table shows us the doctor-diagnosed illnesses which are considered risky comorbidities for COVID-19. And this includes high blood pressure, diabetes, myocardial infarction, chronic respiratory illnesses, cerebrovascular diseases, or cancer. And our results show that about 58% have been diagnosed to have at least one of these 6 risky comorbidities, most common of which is high blood pressure at about 46%. Again, we see that overall, the older females report having been diagnosed with more risky comorbidities compared to their male counterparts. One of the most neglected areas of the study on health and well-being in older years is oral health. Yet oral health has profound impact on the quality of life and can be a risk factor for major illnesses, according to certain studies. The state of oral health of Filipino older Filipinos is quite poor if we base it from the WHO advocated 20 natural teeth for good oral health. So the recorded average number of original teeth for our older persons is only 9. And we see here that the males have better oral health than the females, with the males having an average of 11 teeth on the average as compared to 8 for their female counterparts. 28% of our older Filipinos have no more remaining teeth. And you see here again that the females, more females, about more than a third of them have no more remaining as compared to 17% for their male counterparts. And the situation gets even worse because if you look at those who are 8 years and over, about half of them have no more teeth. So you can imagine the difficulty of chewing and which therefore affects their nutrition and the overall health and well-being. We also studied pain. We asked them if they're troubled with pain. And we see here that about a third of them said they're often troubled with pain. And we asked which specific body parts that they felt the pain. And most of them said it's their shoulders, their lower back, and joint of arms and joints of the arms. So probably arthritis, no related arthritis. We also asked them their history of falls. And we see that about a fifth of them report that they experienced a fall in the past 12 months. And of course, the situation becomes even worse with advancing age. We also gathered information, anthropometric measures, particularly the BMI. And based on the data that we gathered, 56% of them have normal body mass index, 14% are underweight, 22% are overweight, and 8% are obese. And there are more males than females who are underweight, but there are more females than males who are overweight or obese. Functional health. All right. Recent discussions as to whether health should be defined as a state or an ability reflect the shifting definition of health from a static concept towards a more dynamic and functional description or framework. The increasing number of people living with chronic diseases worldwide, many of whom are able to continue functioning and to sustain a feeling of well-being, has led to the reconsideration of the definition of health. So in our study, we also considered functional health of older Filipinos as a measure of health. And we used various sources or indicators, including, among others, activities of daily living and instrumental activities of daily living, or ADLs and IADLs, which is a common measure for functioning ability. So for ADLs, we gathered 7 indicators. We asked them if, because of health, they experience difficulty in taking a bath by themselves, dressing, they have difficulty eating by themselves, standing or sitting from a bed or chair, walking around, going out of their house, or using the toilet. And these are the differences, and we see that the pink ones are generally that's the females, so, and the yellow are the males. So overall, our result shows that about 21% of the older Filipinos have at least one ADL difficulty. And of course, this functional disability increases with advancing age. This is the result for the instrumental activities of daily living, which is a measure for independent living. So we ask our older respondents if they have difficulty performing any of these activities due to health reasons. So some of these are preparing their own meals, purchasing items or medication, taking care of financial matters, so that's cognitive, using the telephone, light housework, using public transportation, and taking medication. So overall, 27% of our older persons have at least one of the IADL difficulties. And we see here that generally it's the women who have experienced more functional difficulty measured by IADLs compared to their male counterparts. One of the measures of health among older people is active life expectancy, which measures the number and proportion of remaining life lived in disability. So in our analysis, we define an older person to be with disability if they reported at least one ADL or IADL difficulty. Our results show that while women outlive their male counterparts because they live longer lives, they spend more years in disability compared to the males. So women have a higher proportion of their remaining life lived in disability. In other words, the males can expect to live fewer remaining years when they reach 60 compared to their female counterparts, but they also have fewer years and a lesser proportion of their remaining life lived in disability. So in our computation, for example, as shown in this table, a 60-year-old male can expect to live 4 years of his remaining life with functional difficulty, which is about a fourth of his remaining life. For the 60-year-old woman, the number of remaining life with functional difficulty will be more than double that of the male at about 8.8 years on the average, representing 40% of her remaining life. So the women live longer lives, but they spend more years in the functional difficulty, whereas the males are expected to live shorter lives, but lesser proportion of the remaining life in disability. How about hair care utilization? Our results show that there's a considerable proportion of our older persons who have unmet need for healthcare services. So about 29% said that they felt ill and thought of seeing a doctor, but did not in the past 12 months. And most of them cited financial reasons for not seeking medical service. So many older Filipinos have limited access to healthcare and limited awareness of some of the government health programs that can benefit them. For instance, 31% of hypertensives and 18% of diabetics obtain free medication from health centers all the time. So actually this question was a rider question requested to us by DOH to be able to know or to assess some of their programs for older persons. Apparently, a lot of these programs addressed for older persons are not yet fully utilized by our older respondents. For instance, another finding is that 41% are aware of the free pneumococcal vaccine program and 30% know of the flu vaccine program. So there's a lot of information dissemination that we need to cover. 80% are covered by health insurance, mostly PhilHealth, but benefits remain inadequate. So I now turn my discussion to COVID-19 in relation to the older persons because my description that I had just made is the profile of our older persons way back in 2018 when it was pre-COVID. Now, COVID came to our shores in 2020, and what is the effect on the older persons? This set of age-sex pyramids show us the changing age distribution of male and female individuals who tested positive from COVID-19 in the last 6 months. So our information here is from 16 March to 16 of September. And we see here that in the initial years, The maroon is the male, and the olive green is the female. So we see here that generally, if you compare, there are more males who are infected with COVID across the population age groups. Okay, but we see that over time there is a changing profile. With the number of as the number of cases increase, the distribution across age groups have shifted, skewing towards the younger population. So we see now that in recent days, most of the infections are concentrated in the younger ages. Uh, this means that over the last few months, there has been a shift in the infections from older to the younger age groups. Particularly, we see here very visibly the 25 to 34. I don't know, it might not be very clear to all of you, but let me show another line graph here that will depict to us the percent share of individuals, no, by age group. So if you see here, in the initial stages, this is in March, April, May, June, until September. And we see here the percentage of positive COVID-19 positive is very high initially for the 60 years and over, but over time, their relative share starts to decline. If you look at the 50 to 59 or the near elderly, it's the same picture that it started high and then the relative share starts to decline. But all other age groups are showing an increasing trend. For instance, under 25 here, we see that a continuous share over time, increasing proportionate share. So with those who are 25 to 34 here, the yellow broken lines, and the 35 to 49. So right now, if you look at the profile, the highest share are those of infections are those coming from the 25 to 34 age group. Here, okay. But the older people are very vulnerable to COVID-19. So if you look at the mortality picture, okay, so this two graph shows us the change in the age structure of the deaths, mortality due to COVID, okay? So during the first 100 days from the inception of COVID-19 in the country, about 71% of deaths were older persons 60 years and over. And as of September 16, or about 6 months after, the older persons still are most likely to die, albeit there is a slight decline in the share from 71% to 62%. So we see here that while there is an age structural change of the COVID-19 mortality over time, with more deaths recorded now in the younger ages, we still see that there's a sustained vulnerability of the older persons, as the highest proportion of deaths are still lopsided in favor of the older persons, 60 years and over. So we all know the government response to protect the older persons from COVID-19. There was a lockdown, and vulnerable groups, including those who are 6 years and over, were prevented from leaving their homes. They were confined to their homes, including the younger ages as well. And there are other things that prohibited them from going out and attending to their usual social activities like everybody else. So for those older persons who are working, this meant that they were deprived from their work, which is their main source of livelihood for many, as reported by some of the older persons earlier. And those working in the agriculture sector also have not been able to market their produce due to travel restrictions. The EC2 restriction has also affected their health and well-being. No? In what sense? The home confinement leads to a more sedentary lifestyle, and of course, it affected the mental health of many people, including the older persons who are unable to see their friends and family as often as they used to. So, as a concluding remark, I think it's clear from our research that prior to COVID-19, older Filipinos are already faced with health and economic challenges. And then COVID-19 is expected to heighten their vulnerability. The drastic change in their daily routines as they are required to spend more time at home, minimize their social contacts with other family members, and the temporary cessation of work and other activities outside the home are expected to affect not only their physical and mental health, but also their economic well-being. So ensuring older persons' health, safety, and protection will require the collaborative effort from government, private sector, the academe, especially for the research and international development organizations, and most importantly, the family, where the older Filipino people are embedded. So this is very true in the Philippines because the main responsibility for the care of older persons is still uh, the Filipino family. So in crafting interventions for healthy and active aging, it's important to take into consideration the scientific evidence to ensure that their unique needs and conditions are taken into account and more keenly addressed. So with that, thank you very much for this invitation and an opportunity for me to share the results of our study. Thank you very much.
All right. Thank you very much, Dr. Cruz. That was indeed a very informative presentation. You gave us a very nice profile of the Filipino older people in terms of their economic status, their health status, even the functional health status. And towards the end, you presented to us that indeed the many COVID infected are, of course, male than female, but during the time it shifted from the older to the younger. And even the number of deaths are still coming from the older. So, young people, please don't forget to take care of us as we stay home because this is the IATF regulation. So again, thank you very much, Dr. Cruz. And so now let's move on to our question and answer forum. And I turn you over to Dr. Hazel Catumblas and Dr. Rosalinda Torres. Take over, please.
Good morning, and thank you very much, Dr. Luna Almansor. Thank you very much, Dr. Grace Cruz, for that engaging and insightful presentation. We will now proceed with the Q&A part of the program, and these are the questions that we have gathered from our Zoom participants as well as from our FB viewer, our Facebook Live viewer. So first question is from Mr. Donald Lipardo. He asks, may we know how older person were recruited in the study, and do they come from all the regions of the country or just in the NCR? And also, in relation to this question, another question states that how many % of the participants were taken from the Mindanao area?
Thank you very much. So as I mentioned, this is a nationally representative sample, which means to say that the cases that we got is representative of all older Filipinos. So we can make inferences about the entire population of Filipinos nationwide. So our sample included those from Metro Manila, the rest of Luzon. We also had sample from Visayas and Mindanao. So we went to all those areas and we translated our questions in various languages so that we are able to gather the correct information from our respondents. We also trained local interviewers so that they can speak the language of our respondents in different parts of the country.
Thank you very much, Dr. Cruz. And another question from Ms. Leilani Arcay. Did the researcher include data that were recorded from hospitals and also in the clinics, and where the super seniors get consultations or hospitalization?
This is just like, thank you for that question. We did not get information from the hospitals. These are just direct responses from our older respondents. And if you see the sample, because they are representative, we have the whole range. We have 60s, 70s, 80s, and we had a few very old. But as I mentioned, the way we sampled them is that we oversampled those who are older ages because the design is panel, which means as compared to cross-sectional where you just interview them one time. The panel design means that you're going to follow through the same respondent over time. And this makes the data more powerful because you can see the transitions that the older persons would experience through time. And the longer the panel will be sustained, but of course that requires a lot of money from the funding agencies, the better it will be, because that means that you will be able to track, the changes that are being experienced by our older persons over time, as they graduate from one, age group to another. So no data from the hospitals. It's just direct questions from our respondents and their experiences. But the illnesses are doctor diagnosed. We asked them if the doctor they were diagnosed by a doctor to have such illnesses.
Okay.
It's not self-reported.
Thank you, Ma'am. I think that our participants are really engaged in your presentation. There are several questions more. I hope, Ma'am, that you can still accommodate. So we have here a question from Christopher Archive. What threats to validity did you try to address in your research? And I think there are two questions here. What selection criteria did you follow in the selection of respondents? So there are two questions from Mr. Christopher Asuncion. What threats to validity did you try to address in your research? And what selection criteria did you follow in the selection of respondents?
Okay, so as I've said, I'll address the second one first. The selection is that you just have to be older person living in community dwellings. In other words, we did not, in our sample, we did not include those who are in institutional situations like home for the aged, and those who are who are priests, for instance, and they are in the seminary, etc. So it's just in those in community dwellings. No? So we got data from the census, and we look at the number of older persons, and we applied some statistical methods to ensure that we applied statistical methods which are proportionate to the number of older persons in a particular locality. So if you want to read more about the sampling technique or the design of the study, you're welcome to visit our website and see the full copy of the report. It's available online, and the way the study was designed and the sampling methods are all laid out there. So the report looks like this, if I can show it. Sorry, yeah. And it's available. Sorry, hindi makita. Hindi makita. So anyway, yeah. So yung validity niya, kasi it's cross-section. It's not experimental, no? So the fact that it is it's a representative sample, no? For us, we can and of course, when we do run models now, we make sure that we take into account the weights, and we also take into account the complex weight design to make sure that all those limitations of the sampling are taken care of. Let me assure you that in the computation of our estimates, we have also in our team the statistician from the UP School of Statistics, and our consultant is also from Nihon University, who's done aging research in many parts of Asia and the rest of the world. So he's he's very knowledgeable. They're very knowledgeable on the science of collecting information to make it a representative sample of the country's older persons. And therefore, we can make conclusions about the entire population of older persons 60 years and older. Thank you.
Thank you, ma'am, for gracefully responding to the query. And thank you for sharing the result of the research. Ma'am, we still have another question from our
For
Q&A
sure.
chat box. Did the research include health coverages such as PhilHealth and other private health coverages and the type of health coverage such that of free health care or a private health coverage?
Yeah, we did. And I think I presented part of the findings, and we said that most of their health coverage is really PhilHealth, no? Either as a member or as a dependent of their children. Probably their children are working, but we also saw that a lot of them said that there's still a lot of unmet need for healthcare. Their access is still hampered because of economic reasons, even with their PhilHealth. Most of them have PhilHealth. Very few reported that they have other sources of health insurance.
Thank you, ma'am.
Thank
So,
you. Yeah.
yes, we still have quite a number of questions. I believe we can accommodate probably a few more questions. Ma'am, there is a question from Angela Zabala. Good morning, ma'am. You've mentioned earlier that there are free pneumococcal vaccine offered to older people. What hospitals offer that free vaccine? Maybe, ma'am, you can give some of the hospitals that are giving this. You have mentioned the free pneumococcal vaccine.
I hope that there are DOH people here because it is really the point person of DOH, Dr. Mimi Binduan, who suggested that we test this. Supposedly, these are the available vaccines provided by DOH, and they should be available in barangays and public hospitals. No, so that's what the program. Maybe Dr. Shelley can also mention or discuss this later, but these are supposed to be available in the government hospitals. So I presume in the, if you go to a public hospital in your region, in your province, or in your barangay center, those vaccines and medicines should be available. And I heard some older persons who said that they get free medicines for their diabetes in their barangay centers. So if I go to, let's say, Bulacan, and then I hear stories that they get their free medicines from the barangay center. So yeah, because I also validate whenever I see, older persons, and I inquire from them informally. And so there seems to be, at least in nearby areas in Metro Manila. I don't know in far-flung areas, because as we see from the results, there's a lot of, older persons who are not yet aware of this program, that they can avail of free medicines. And I don't know about availability as well. Thank you.
Thank you, ma'am. We are receiving here a lot of commendation. Thank you very much for the research presentation. It's very, very informative. So thank you very much, ma'am. Probably we still have, in the interest of time, ma'am, there are a lot of questions, but rest assured that these questions are well taken care of and will be sent to our speaker. We will now turn over the floor back to our speaker, our host, Dr. Nuna Almansor.
Okay, thank you very much, Dr. Catublas. And again, we would like to thank Dr. Cruz for that very informative presentation. At this point, we would like to call on our Dean of the Institute of Nursing, Far Eastern University, to present virtually the Certificate of Appreciation to our speaker. May I call on Dr. Maria Belinda Buenape, please. Thank you.
Okay, good morning. Thank you, Dr. Cruz. Your insights into the health status of the Filipino older people is very informative, but quite disturbing to know that 58% have at least diagnosed with comorbidities, which made our elderly more vulnerable to COVID-19. So at this point, we would like to award the Certificate of Appreciation to our first speaker. But please allow me to read the citation. Metro Manila Health Research and Development Consortium, in cooperation with Far Eastern University and Our Lady of Fatima, presents this Certificate of Appreciation to Dr. Grace T. Cruz for exhibiting exemplary knowledge and competence as speaker in the webinar, The Road to Super Senior, The Science of Aging Session 2 with the theme, It's Earlier Than You Think, but It's Never Too Late. Given this 19th of September 2020, okay, signed by Generoso Pamitan, Director, University PhD, Director, University Research Center, Far Eastern University, Professor Michael Joseph Dino, PhD, Director, Research Development and Innovation Center, Our Lady of Fatima University, Hilton Lam, PhD, Director, Metro Manila Health Research Development Consortium, and Carmelita Padilla, MD, Lead Convener, Metro Manila Health Research and Development Consortium. Again, thank you, Dr. Cruz. Maraming salamat po.
All right. Thank you very much, Dr. Benope. Thank you again once again, Dr. Cruz. Moving on, let's have our second speaker. Our second speaker is a graduate of BS Psychology at the University of the Philippines, Diliman, with a Latin honor, BS Psychology cum laude. And she finished her Doctor of Medicine, also at the University of the Philippines, and have been trained in international medicine at the State University of New York, after which she also served there as a chief resident. She also did a 2-year fellowship in geriatric medicine at the Division of Aging, Harvard Medical School in Boston, USA. Dr. De La Vega is the founding director of the Center for Healthy Aging, and she's also the founding director of the Alzheimer's Disease Association of the Philippines, and she pioneered the establishment of the first geriatric multidisciplinary outpatient clinic in the Philippine General Hospital. Dr. De La Vega is a professor of the University of the Philippines College of Medicine and a director of the Institute of Aging at the National Institute of Health, UP Manila, and a lifetime fellow of the Philippine College of Geriatric Medicine. Ladies and gentlemen, let us welcome Dr. Shelley De La Vega as she presents Community-Based Care for Dementia. Dr. De La Vega, please.
Good morning, everyone, and good morning to our super seniors and soon-to-be super seniors. Thank you very much to the MMHRDC, my friends and colleagues there, for inviting me to give the opportunity to share what we have accomplished at the Institute on Aging together with our partners in order to improve the delivery of care to older persons with dementia living in communities. Next slide. So the objectives of my talk are the following. First, because this is about community-based care, I would like to run through a series of WHO, WIPRO Mental Health and Substance Abuse funded, WHO Philippines funded, and DOH partnered community projects with the Institute of Aging of the NIH. We will talk about policy strengths and gaps on dementia at the national and local level. We will talk about the recommendations by stakeholders of various institutions dealing with older persons with dementia. And then we will describe the training of trainers on 2 documents that we have prepared to improve health human resource. That is the Community Toolkit and the MH Gap. And talk about how we enabled community engagement and established linkages. And of course, we'll mention the ongoing regional geriatric training. Finally, because this is about community-based care, I'm going to report to you the recent international recommendations on dementia by the Lancet group. Next slide. So what is dementia? Dementia is a disease that affects memory, but it's not just about memory, forgetting where you put your eyeglasses or forgetting names of people. It also affects daily function, and it can change your personality over time. So it's not about just memory, remember that. Unfortunately, dementia increases by proportion as we get older, so that by the age of 90 years, almost 50% of older persons will already have some form of dementia, especially the most common, which is Alzheimer's disease. Unfortunately, again, one irreversible risk factor aside from age is the female sex. We still have to understand why this is. And of course, there is genetic predisposition to disease, especially in those families where Alzheimer's disease happens in younger age groups below the age of 70. And it is linked to the ApoE4 gene. Next slide. Now, I mentioned earlier that I will talk about the Lancet Commission recently published work. And here they identified 12 dementia risk factors that we can deal with at the community level. So these are conditions in the early life. For example, if we want to prevent dementia, those below 45 years of age should really engage in more education. More, at least secondary education, beyond is even better. And for those of us who are mostly in the middle age, at this age, we need to address any hearing loss. Traumatic brain injury from accidents especially should be reduced. Hypertension should be well controlled, if not prevented. Alcohol intake should be limited to less than 21 units or 10 ml per unit. And obesity should be reduced. And obesity here is defined as the body mass index of more than 30 kilograms per meter squared. Now, at a later life, those aged 65 years and older, in order for you to prevent dementia, you need to stop smoking. You need to address depression and social isolation. As mentioned by Dr. Cruz, COVID is endangering older persons because of social isolation. It's making them depressed. And many persons with dementia are getting worse in terms of their symptoms with this social isolation because of COVID. Physical inactivity is also a late life risk factor for dementia, diabetes, and of course, recently, the Lancet Commission has identified air pollution as one major risk factor for dementia. Next slide. So how about dementia in the Philippines? Why is it important for us to talk about it? Dementia just doesn't affect just the individual who suffers from the disease, but the family, the caregivers, the community, and of course the nation that shares the burden of the disease. The total cost of dementia care in the Philippines has been estimated at 849.2 million, with 321.3 million spent in informal care. That means family caregiving. Assuming that a family member or informal carer spends 1.6 hours per day providing activities of daily living care. And this was a research done by WIMO in 2009. And we know, those of us who take care of people with dementia, that we don't spend just 1.6 hours per day taking care of them. We spend the entire day taking care of them, especially as the dementia gets worse. So the estimate here is grossly underestimated. Next slide. So we were able to proceed and publish a paper on the status of dementia care services and workforce in the Philippines. My team in the UP Manila had funding from the Department of Health, and we went to 26 of 4 institutional settings. And these were purposely sampled in Luzon, Visayas, and Mindanao. We went to private and government hospital, private and government homes for the aged, or institutions for older people. And we realized, based on that published study, that although there were enough general physicians and nurses, there was a scarcity of specialists who took care of older people with dementias, particularly geriatrics. We also found out that there were physical therapists, yes, but they were mostly outsourced. But we also found out that occupational therapists are rarely seen in these institutions. Now, we also realized that majority of the workforce, or 73 out of the 167 that we tested, did not have training in dementia care. Unfortunately, this affected their knowledge on dementia because 27% defined dementia correctly. Only 27% really knew what dementia was all about, even if they were already taking care of people with dementia. However, good to know, because probably of our culture, the attitude toward dementia was very positive among the caregivers and hospital administrators in the form of willingness to care for and willingness to learn more. So how did we and how are we addressing these institutional challenges on health human workforce and knowledge, etc., on dementia care? Now, let me introduce to you, next slide, the WHO dementia projects, which we had the fortune of working with. Next slide. And this is the project overview, funded through the government of Japan, through World Health Organization, Mental Health Substance Abuse Unit, and the WHO country office in the Philippines, implemented by our institute and the UP Manila Foundation in partnership with the Department of Health. So far, what we have accomplished thus far are, next, sorry, let's stay there. We identified and involved relevant stakeholders. We obtained data relevant to dementia in the Philippines. We gathered issues and concerns regarding dementia management. We localized the MHGAP, or Mental Health Global Assessment Plan tool, or it's a work tool actually for dementia care. And we created a dementia toolkit training material that is localized to our local Filipino language, and we provided a local language translation to the toolkit. Next, of our accomplishments, we developed the core faculty of dementia experts or trainers who will train the trainers and train non-specialists in hospitals. And these include tertiary hospitals in Quezon City, physicians, nurses, administrators there. Using the MHGAP, we train them in providing dementia care, as well as we train community workers in the barangays within Quezon City on how to use the dementia toolkit, in trying to raise awareness, how to refer to physicians and specialists, and how to support carers or caregiver support of people with dementia. And finally, because of our numerous stakeholder and policy meetings, we were able to identify challenges and elicit a priority list on dementia policy in the Philippines. Next slide. So I will just run through a series of how these have all happened. So back in 2018, the DOH hosted the first stakeholders meeting held there with the WHO. Next is our situational report. Next slide. We had, as a method of gathering the situational report, next slide. Okay, we had a review of literature. We looked at the WHO, MHGAP, the Dementia Toolkit for Community Workers, the paper that I just mentioned that was published on workforce. We had several stakeholders meetings, we had surveys, and of course, we also had key informant interviews. So what was the result, therefore, of all of these various methods of data collection? Next. So I'm just going to show you a portion. This is just maybe 1/5 of the entire document that had already been analyzed and submitted. But at the national level, we knew then, and probably is true at the moment, that with regards to the burden of disease, 1 in 3 Filipinos has a mental health problem. Now, with regards to mental health policies and programs, we have a bill called the Mental Health Act of 2017 and a House bill, the Comprehensive Mental Act. And I think this is already merged into one mental health law that is now hopefully going to be implemented together with the National Mental Health Program Strategic Plan 2018 to 2022. The lead agency for this is the DOH DPCB, or Disease Prevention and Control Bureau, and they are in charge of that mental health program, and they are going to receive, hopefully, fully at least 2.44 billion pesos in the budget of the DOH. Next slide, please. We also learned that with regards to capacity building, the DPCB has already been implementing the Mental Health Gap Action Program training modules. But at that time, their training modules did not include a module on dementia. They had modules on depression, on seizures, etc. But dementia was not yet being implemented. But at least 34% of the municipalities in the countries had already received the MHGAP modules. With regards to health facilities and resources, we learned that there were a lot of free medicines in 70 government facilities all over the country. And these medicines were for people with mental health problems. But none of these medicines were medicines for people with dementia. And so, where were those medicines for mental health? They were in public hospitals and standalone psychiatric facilities that were identified and approved by DOH. Again, no dementia medicines in those facilities. Next slide. In terms of the involvement of private organizations, good to know that we have at least 2 major medical organizations that are actively working with the public and with the DOH and other NGOs on how to care for the persons with dementia, how to care for their families. For example, the Alzheimer's Disease Association of the Philippines has even published a book called The Recommendation on Diagnosis, Prevention, and Management of Alzheimer's Disease. They're already on their 2nd edition. And they continue to do lay fora. The Dementia Society of the Philippines also takes care of persons with dementia and their families and has done a lot of education, research, and policy development and advocacy projects, including outreach modules on dementia surveillance. Next slide. At the level of the district, what we found out was there were very few community or dementia-specific recreational activities, specifically for persons with dementia. So that is a great lack. Our CHOs had no planned community activities for persons with dementia. There were no support groups at the district level, but NGOs were quite active, no, in that regard. With regards to dementia care training, again, there was no dementia-specific training program at the district level. And only LGU-funded MHGAP training had been done at that time in cooperation with the UP, PGH, and DOH regional office in 2017. Next slide. Continuing on at the district level, there were really a lack of data to describe attitudes and behaviors for dementia, to have public education campaigns, etc., etc. But there were plans to create a mental health handbook, for example, and an initiative was from the mental health. I think that was from UP Manila and Manila itself, no mental health handbook. Okay. Next, at the district level, one socio-cultural factor that was studied was, again, a general lack of dementia-specific services, barriers identified, evidence of health seeking. So as MMHRDC members, you might be interested in doing research in these areas. And there were no known explanatory models of dementia mentioned in our research. Okay, so we had a lot of deficits with regards to health human resource, service at the community level, and knowledge at the community level. So how did we address what were identified as obstacles? So continuing on with the projects, next, we now are going to talk about how we have addressed, to some extent, no, it's just a start, the health professional training needs of our community members. Next, so we will talk about the adaptation guide for MHGAP 2.0. No? So the MHGAP is an international document, international project by the WHO, and there are many modules that have already been created in the English language, in various languages all over the world. And again, like I said, talks about many things, including dementia. So what we were able to do was we were able to adapt the existing English version, MHGAP Dementia, into Filipino, and use actual medical information that was relevant to the Philippines. We clarified the medical terms and really looked at the culture and how to adapt the MHGAP to the Philippine setting. And we had, of course, a lot of good experts in the field who participated in that project. So we also were able to create a storyline about an older Filipino, and that storyline and module was also enhanced by a role-playing part of the module that really improved on the teaching component. Okay, so next. How did we address the health worker training need? Next, we had a dementia master trainers workshop. So master trainers are those who will train the trainers. Okay, so these people were chosen because they had a very good track record in dementia. They were already very much involved in dementia education, in outreaches, and some also in research. So we had in that group, you will probably recognize some of your colleagues in the nursing profession. We had nurses here. We had physical therapists, neurologists, psychiatrists. We had geriatricians. We had family physicians, internists, etc., etc. So it was a very good group that we first trained. Okay, next. So these master trainers were then the ones who continued to do the community training of our community workers using a newly developed dementia toolkit. Next slide. So what is that dementia toolkit? This dementia toolkit is available for free online. Okay, just type WHO Dementia Toolkit for Community Workers in Low and Middle Income Countries, and you will get the full document online. So this document talks about what is dementia, what are the risk factors for dementia, what is healthy aging, what can we do with regards to healthy aging in order to prevent dementia in our communities. How do we recognize people with dementia in our communities? What services should we offer at the community level for persons and families of persons with dementia, etc., etc. So it's very laymanized, and it is meant for people of at least secondary education who speak either English or Filipino, because we have translated it in Filipino, and who are willing to take care of older persons and work with their barangays or communities. So next. So we now have a dementia supplement in Filipino, and that is also available upon request. And I know that many of you nurses especially are already using this in your courses. No? So, next slide. Continuing on to how we have addressed that community training needs, just nice pictures on how we enjoyed that training. So we really had, aside from plenary sessions, we had role-playing. One was playing the role of a caregiver, a family member. One was pretending to be someone with dementia. And then in the dementia toolkit, there are checklists that you need to accomplish to help assess your community readiness for care for dementia. So I will show a few of those checklists later on. Next slide. So finally, we had a graduation of maybe about 40 of the trainers, and hopefully they are already influencing the way you teach dementia. Next. So we had a dementia policy stakeholders meeting now, because we wanted to understand what are the policy gaps, policy needs. Next. So this is the list of those who participated in that dementia policy stakeholder meeting from WHO, DOH, JSWD, the Institute on Aging, NIH, CAMP, College of Nursing, etc., etc. Most major societies of health professionals, NGOs, a Home for the Aged, etc. were there. Next. And again, one of the things that we thoroughly enjoyed, because these are like-minded, like-hearted people. And we spent I think one whole day doing that. And finally, this is just a portion of our output. I will not show anymore what the needs are, but these are the recommendations from these stakeholders. First recommendation is the promotion of awareness and understanding of dementia through learning activities, no? To produce more local materials, to implement the WHO Dementia Toolkit for community workers in low and middle income countries and their supplemental Filipino version, to identify champions and dementia advocates, to educate the caregiver, to reduce caregiver burnout, no? And caregiver support is very necessary. And then to incorporate awareness and understanding on elder abuse in our trainings. Next. Some other recommendations aside from awareness is caregiver support. So we understand that caregiver support is not just through counseling, but they also need financial support, no? So financial support such as tax exemptions, paid leaves, and other compensations, because sometimes they no longer work in the jobs that they were meant to be at, no? But instead spend a lot of time with people in their families that they need to take care of. Also in the caregiver support, to include the WHO Dementia Toolkit recommendations on caregiver support. And in fact, there is an app, the WHO already has a dementia app that will help caregivers that is downloadable for free. Also, we talked about long-term care services, no? And that we need to develop a community-based long-term care policy. And of course, provide plantilla positions or salaried positions in government for the health workforce, and service compensations, for example, from PhilHealth, because home care for older people with dementia is not covered by PhilHealth. Even if many older persons have PhilHealth, they will only be able to enjoy their PhilHealth benefits if they are hospitalized, but not when they are at home and not when they need to go to outpatient clinics for their health maintenance, okay? And of course, we would like to suggest special compensation packages for workers in long-term care, and of course, to explore long-term care insurance. And finally, for MMHRDC, because we are in research and development, these are our research, next slide, our research recommendations. So what are our priority areas in dementia research? These are prevalence, needs, service, resource, and workforce. So there is now a global dementia observatory research going on by the WHO and DOH. But we need to help each other in generating more report on the national, regional, and district levels. And of course, to address data gaps through better, more capacity building on research. How do we do research on persons with dementia? Funding support from PCHRD, DOH, of course, and other international partners in research. We need to harmonize our methodologies so that we don't, when we get into a description of what dementia is, what frailty is, what activities of daily living is, we are only talking about the same thing because our methods are harmonized and our measurement tools are harmonized. And of course, to validate existing dementia screening tools and develop Filipino screening tools for dementia. What we have in existence, unfortunately, is not always free and may not always be culturally perfect for Filipinos. So we need to develop our own tools. Next, please. We're almost done. So after their training, we continue to scale this up. We continued to scale up this project, the Toolkit and MHGAP. Next. And we were able to now train community volunteers and community workers on how to use the toolkit. And again, non-specialists in hospitals, in the Quezon City, because that was our pilot area, were also trained on MHGAP. We were able to identify their service needs. We established a referral scheme between the barangay and the hospital. And we were able to train a total of 55 community workers on how to use the community toolkit and 58 non-specialist healthcare workers in hospitals. Next. So I talked to you about the Dementia Community Toolkit. You will see here a sample of the checklist that is provided there, because we want the community to know what are your community needs, no? And how are you progressing now that you have been trained in dementia identification, etc. So we have identified some outcome indicators, some outcome indicators on awareness campaigns that have been established, on involvement of community leaders. So these are some of the checklists that we are recommending to be tracked by our trained community workers. Next. And of course, we were able to share with them a referral note, so that if a person with dementia or a person suspected of having dementia presents at their barangay clinic, or even just at the barangay hall, you know, they can provide a referral note to the hospital that they are linked to. And the hospital at the same time will provide the barangay that referred this patient with their assessment and further plan on how to do that, no? So next we just have a few of the training and trainees in the communities. And really, we had barangay tanods, we had family members, we had barangay officials. Of course, we had doctors and nurses there who were involved, and our partner agencies also visited these sites. No? Okay, finally, so now somehow we have some idea of how to take care of our community members. And of course, we already identified earlier the risk factors that we may be able to reverse, no? Or improve upon when we provide community services for these people. So going back again to the Lancet Commission, the international recommendations of the Lancet Commission, it's a big document, no? It includes testing for dementia and medications, but we're not going to talk about these. We are going to talk about what recommendations have relevance to communities and community projects. Okay, next slide. So in that Lancet Commission, they talked about dementia prevention. And this is where dementia is at the moment, because there are no medications available that will reverse or treat dementia. Remember that. So dementia prevention is now where we are focused when it comes to dementia care. So there are two elements of dementia prevention. First, to reduce neuropathological damage. And second, to increase and maintain cognitive reserve. Okay, how do we reduce neuropathological damage? We do that by minimizing diabetes, treating hypertension, preventing head injury, stop smoking, reduce air pollution, and reduce midlife obesity. That will reduce the damage to the brain and our brain cells. Next, increase and maintain cognitive reserve by recognizing and treating hearing impairment, maintaining frequent social contact, and attaining a higher level of education. Now, between these two, there are some recommendations that will enhance both, no? And improve and help you prevent dementia. And these are frequent exercising, reducing the occurrence of depression, if not early recognition of depression, and avoidance of excessive alcohol intake. So if you notice, many of these can be done on an individual level. However, we need the community and government, maybe our local authorities, and even social, maybe NGOs, no, or lay organizations to help us in being able to do what are recommended here. So I have summarized and interpreted these as follows. Community and population intervention include, therefore, enhancing early education. Now, improve early education. We need social public health programs to reduce hypertension. So it's not just medications for hypertension, but what we eat, our high sodium diet, our high cholesterol diet. Now, these have to be addressed. Policies that encourage social, cognitive, and physical activities through the lifespan, because healthy aging really is a lifespan approach. Remember, we prevent dementia even before the age of 45, and even young children, even healthy mothers should be supported, because they will give birth to healthy children, and these healthy children will grow up to be healthy adults and super agers when they age. So we need to study hearing loss, no? And intervention to reduce the risk of hearing loss. We need to reduce the risk of traumatic brain injury, and the approach can be occupational, providing helmets, for example, at work, making our workplaces safe, and even transportation, of course, simple wearing of seat belts and helmets, no? Very important. These have to be implemented, and we need a national and international policies to reduce air pollution. Now, very challenging. Probably this is also linked to climate change. And of course, to reduce exposure and reduce uptake of tobacco. And for those who are smoking tobacco, to undergo a smoking cessation program. So not just the individual, but the society, the community, and the nation. And the international community need to provide and address these policy issues. So, next slide. We invite you to participate in the National Health Research Forum on Aging on October 7, because the Institute on Aging will present the data on its Fit for Frail research project on healthy aging and frailty. The focus of the PCHRD and HRFA will be on COVID and universal healthcare. And we have data there from Fit for Frail regarding the health systems. How is the health system with regards to the support of older persons who may have COVID now and in the future? What are the risk factors of older persons that lend them vulnerable to a higher death rate, for example? You will hear about that. And of course, we have in partnership with, as part of our research team, we have a medical anthropologist who will tell us stories about what her learnings are. Aside from that, we will be having a webinar series on research methods and harmonization. So we will invite you to enroll in that webinar series. We will contact you through the MMHRDC so that you will learn about research methods, and so that you can replicate what we have done in the Fit for Frail. The Fit for Frail is a research project funded by DOH, PCHRD, through the Institute on Aging. So in ending, I would like to acknowledge the WHO, WIPRO, DOH, UP Manila Development Foundation, the NIH, our partner barangays and hospitals, and of course, our staff in the NIH UP Manila, our advisors and our faculty. Thank you very much.
All right, thank you very much, Dr. De La Vega. That was indeed a very educational and informative presentation. We learned that dementia is not only loss of memory, but our daily functions and even our personality. Wow. We also learned the various risk factors that may cause dementia. And I agree with you. We don't spend only 1.6 hours per day, because I took care of my mother too, the whole day and throughout your life. And we also heard about caregivers, their need for support, no? And the development of some policies. I encourage everybody to look at and let us avail of the dementia toolkit that Dr. De La Vega has been mentioning, so that we could also help our community and see what are the needs of our people in the community to avoid dementia. So we would like to call on the relevant agencies for the implementation of the various recommendations cited by Dr. De La Vega, and also for the researchers to do something about those gaps. And we thank you for that Lancet dementia prevention kit that you have been saying, that we should do exercise, reduce depression, even we're staying at home because of COVID, and avoid excessive alcohol. Thank you very much, Dr. De La Vega. And now,
Thank you too.
let us move on to our question and answer. And I turn you again over to Dr. Catublas and Dr. Torres, please.
Thank you very much. And congratulations, Dr. Shelly Ann de la Vega, for the very informative, timely, and relevant presentation. It was really a pleasure to learn so much on neurocognitive disorders such as dementia. And as evidence of the interest of all the participants in this topic, we have quite a number of questions, but in the interest of time, probably we could just accommodate around 5 questions for this particular topic. So let me start by reading the question from Mr. Donald Lepardo. What is the prevalence of dementia in the country?
Okay, very interesting question. It depends on who is doing the research. We noticed that if a neurologist or a mental health professional or a mental health group is doing the research, the prevalence is higher. You will hear about some prevalence data that was gathered years ago through a Delphi approach, meaning to say they just interviewed specialists like geriatricians and psychiatrists and neurologists on what is the prevalence of dementia in your clinic. And of course, if that is the case, you will come up with high numbers, maybe 14%, 16%. But in our community-based studies, the dementia prevalence is only about 4%. And I don't know if Dr. Cruz can add to that if she had any. But we will present more of that data. Remember, I am inviting you on October 7 and the webinar series. We will have more data there on the prevalence of dementia in our study. But in our study, what we did was we used the MOCA, Montreal Cognitive Assessment Form, but also we had geriatricians trained in managing and assessing dementia. And they were the ones who did the final diagnosis for dementia and cognitive impairment. But so the numbers are about maybe just 4%, 7%. And it also varies depending on whether it's in the NCR, whether it's in the provinces. So very exciting data.
Thank you, ma'am. Another question from Christopher Asuncion. Do we have enough doctors in each province or in the Philippines in general that specializes the cure or prevention of dementia, particularly among the middle-aged group?
Yeah, I think that was the answer to that is in our paper, the status of dementia care workforce and services in the Philippines, that is available in the Journal of Clinical Epidemiology, which I presented earlier. We don't have enough. Definitely, we will not have enough. We will not have enough neurologists. We will not have enough geriatricians or psychiatrists who are specialized in dementia management. That is why we are training non-specialists in how to recognize and manage basic management of dementia. And that is also why we are capacitating community workers to also do a portion of that job. But what we also have realized is even our allied professionals are not enough. No, we need PTs, we need OTs, we need speech pathologists, we need psychologists, we need so many people to take care of people with dementia, and we need to just train them. Let's not rely on specialists, and for that matter, not just physicians. And again, sorry po. But remember, the Fit for Frail study has a very good health systems research, and they were really able to go to all regions of the Philippines, look at the health workforce, and we will present that in our webinar series. Very exciting data.
Thank you, ma'am. We have here another question. I think this is on the complementary and alternative medicine. So we have a question from Miss Elaine May Arcay. Do we have previous studies about herbal medicines or vegetable and fruit that reverse or cure dementia? And ma'am, in relation to this, there is also a question from, this is actually from India, from Dr. Kamal Banik. What is the best traditional medicine for dementia?
Okay, so remember, there is no known cure for dementia. There is no known medicine that will reverse or treat, not even supplements. Supplements and dementia have been studied for many years now. Unfortunately, none of them have been shown to reverse, prevent, or cure dementia. So we really are still looking, however, for a lot more evidence for these. So we have negative studies, for example, for just plain ginkgo biloba, for vitamin E, for anti-inflammatory herbal medicines that are being promoted outside. And so really there is none to recommend because unfortunately the scientific data has shown very poor outcomes or unreliable outcomes, and many of them are poorly designed studies on herbal medicines for dementia. So we need better designed studies. We hear a lot of stories that they work, but if you look at the science of it, the science is very poor. So we really need that.
Thank you, ma'am. With your answer, you actually did answer this next question. Are there previous scientific studies that prove that dementia can be cured or prevented? You have actually answered this question already.
But remember, look at the recommendations. Treating hypertension in midlife is one of the most powerful ways of preventing, not treating, but preventing dementia. In fact, if we take care of our hearts, we take care of our brains. So the recommendation now is, if you are hypertensive, make sure you have a good diet, lifestyle, you take your antihypertensive medicine. If your blood sugar is elevated, make sure that you, again, have a healthy lifestyle, reduce your weight, be more active, take your diabetes medicine, make sure your medication for diabetes and hypertension are well established. So these are some of the most powerful medicines, if you will think about it, medicines that will protect the heart and the brain at the same time.
Thank you, ma'am. Probably this will be the last question. This is an interesting one. Is it true that seniors and super seniors playing chess are less likely to develop dementia than those who do not play chess?
Well, no, chess, not just chess, but I think more better study than chess would be mahjong, diba? There are more studies on mahjong. These are social events, diba? You enhance your brain, you think thoroughly about your moves in chess. But remember, people who play chess are probably more highly educated. Yes. So it's not just the chess, but it's the level of education of the chess player, the availability of interaction, which is very good. No, social interaction is very good when you're playing chess or mahjong. But a combination of physical activity, walking, no, not just brain activity. In fact, in this recommendation, physical activity is more recommended than brain exercises. But of course, a combination of both will not be will also be beneficial.
Yes. Thank you very much, Dr. De La Vega, for graciously sharing your valuable insights. So let me now turn over the floor back to Dr. Luna Almansor.
Okay, thank you very much once again, Dr. De La Vega. I will remember that to take care of my heart. I will do exercise aside from brain exercise. Thank you so much.
Thank you. Thank you.
Yeah, at this point in time, we will now call again Dr. Maria Belinda Buenafe, the Dean of the Institute of Nursing, Far Eastern University, to present virtually our certificate of appreciation for Dr. Cheryl De La Vega.
Okay, good morning
Ma'am,
again. Thank you, Dr. De La Vega, for your insights. So participants, we can check with our local area or agency on aging to find what services are available to assist dementia caregiver and community health workers, like the use of toolkit and training for caregivers. Okay, at this point, we would like to award the certificate of appreciation to our second speaker. Please allow me to read the citation. Metro Manila Health Research and Development Consortium, in cooperation with Far Eastern University and Our Lady of Fatima University, presents this certificate of appreciation to Dr. Shelly Ann De La Vega for exhibiting exemplary knowledge and competence as speaker in the webinar, The Role to Super Seniors, The Science of Aging, Session 2, with the theme, It's Earlier Than You Think, But It's Never Too Late, given this 19th of September 2020. Again, marami pong salamat, Dr. De La Vega.
Thank you, Dr. Buenafe. Thank you to the organizers. I will try to answer the Q&A and type in my answers to the Q&A. Thank you very much.
Thank you very much. Thank you for that. And so now, after listening to the effect of COVID-19 to our elderly, we jump to dementia. So now let's listen to our last speaker, but not the least, on what kind of food shall we be eating as an older people. So our last speaker is the Chief of Nutritional Assessment and Monitoring Division of the Food and Nutrition Research Institute. She is a scientist too of the Department of Science and Technology. She obtained her doctoral degree in nutrition at the Regional Center for Community Nutrition, CIMEO, Trommet at Jakarta, Indonesia, and graduated with a Latin honor as cum laude. Dr. Agdepa is instrumental in developing research with information and used in the different laws, which is used in the development of the nutritional education and supplementary feeding to lead for the release of the National Supplementary Feeding Law. She is also instrumental in developing the policies and resolutions for the commercialization of iron-fortified rice. And she participated in the team who crafted the DOH administrative order for the increase of budget for dietary section and cost of meals for inpatients and the use of low-protein rice for CKD patients. Dr. Agdeta has been a short consultant also in the Nutritional Institute of Nutrition, Hanoi, Vietnam. And as a scientist, she has been recognized and received awards as Pag-asa Award by the Civil Service, awarded by the Office of the President. She has been awarded as Alberto Romualdez Outstanding Research for Health Research and a Clara Ruth Derby Award for Nutritionists, and have been awarded as one of the 10 outstanding leaders in nutrition. And currently, she is a member of the Board of Examiners for the Board of Nutrition and Dietetics in the Professional Regulations Commission. Ladies and gentlemen, let us welcome Dr. Imelda Angeles Agdepa to present to us nutritional data on Filipino aging population. Dr. Agdepa, please.
Thank you, ma'am, for that very generous introduction. So, to the Metro Manila Health Research and Development Consortium, and to the organizers of this webinar forum, magandang umaga po. So, may I ask to share my screen for my presentation? So allow me to present these in this track First, I'd like to introduce, of course, our agency, and then moving on to the nutritional data of the aging population as a result of our National Nutrition Survey, and just discuss in brief possible actions for care. And that is actually our institute. It is actually the premier research agency of the government in nutrition, food, science, and technology services. You can see that there are vegetables in front of our building because we were motivated to plant that because of the result of our National Nutrition Survey, wherein vegetable consumption is declining. And we just like to project that in any corner of the house or in any corner of a perimeter in the house, land spaces, you can actually plant vegetables. So as mandated by law, the DOST FNRI undertakes researches that define the nutritional status of the population and determine or identify malnutrition problems, its causes and effects. After determining this, we have to develop and recommend policy options or strategies and diffuse these these technologies to the relevant stakeholders. So you can see here, the first mandate is the one that is to be presented this morning. That is the defining the nutritional status of our Filipino population. So through the years, the DOST FNRI has been conducting national nutrition surveys from 1978. Why is there a need to evaluate the nutritional status of Filipinos? Because we do believe that data gaps are really hindering accountability of progress. And because assessing the nutritional status provides an indicator to track changes or improvement for better and appropriate development plans. The components of our National Nutrition Survey is from A, B, C, D, and of course, until the maternal and child health. Anthropometry for the weight and height for all population groups. Biochemical, we actually do the different lipid profile, FBS testing. We also do UIE, no? And urinary iodine excretion, and also other intended or sponsored researches like zinc levels and folate levels. So we do dietary survey wherein we have the household weighing for the household measurement, and we do the 24-hour recall for individual level. For the 24-hour recall, we do it on 2 non-consecutive days. For the interview, we have the socio-economic status, the food security, infant and young child feeding, and maternal health. For the clinical aspect, we measure or we assess hypertension and also lifestyle behaviors. So from 2018 to 2020, we had a rolling National Nutrition Survey. Now, previously, the National Nutrition Survey was conducted every 5 years. And in between that 5 years, we do the updating survey. However, because our lawmakers had mandated us to do it on a yearly basis because the 5-year plan was actually tulong for them to do adjustments in the different development plans. So we actually decided to do the 3-year rolling survey to have a data for the 117 provinces and highly urbanized cities of the Philippines. And therefore, local data have to use their own data, like at the provincial level. So for 2018, we finished 40 provinces, and also in 2019. However, for 2020, we were not able to finish, or we were not able to cover the provinces. It's just because we pulled out our teams due to the COVID-19 pandemic. And hopefully by 2021, we can continue with the 37 provinces that were left behind for this rolling survey. So let me now proceed with the physiology of the aging population. The process of aging affects nutritional needs. Although some nutrient requirements may be reduced, some evidences indicate that requirements for other essential nutrients may increase later in life. And just to show you that the energy requirements of aging is still very high. From 60 to 69, that's actually 2,140 kilocalories, and it will just decrease if the older population or the super senior, that's actually 80 plus already, and it's decreased 1,960, and this is lower among female population. However, for the macronutrient distribution range, this is actually provided also in our PDRI, or the Philippine Dietary Reference Intakes. And these are the different fat-soluble vitamins. I just like to project to you all this, but I don't need to read because it is actually downloadable in our website. And also the B vitamins. B vitamins, why? Because this is actually important for the nerves of our elder population. So protein, I just like to stress that protein is necessary for building up muscles among our elderly population. This is to replenish vital body fluids and the wear and tear of the body. Older populations are actually vulnerable to protein deficiency. Why is it so? Because alterations in the basal metabolic rate and slowing metabolism leads to the replacement of proteins with fatty tissues. And why did I stress protein? It's just because lower protein intake is actually experienced because of physiological changes. And you have seen a while ago in the previous presentations, worsening medical conditions during the during aging, physical disability and mental disorders, which is just presented. And of course, you saw also in the first presentation, the socioeconomic conditions is really not that good, and the genetic predisposition. And why are we recommending a higher protein needs? Because of anabolic resistance, low postprandial amino acid availability, decreased muscle perfusion, sarcopenia, and the disease-related protein catabolism. Now, the key nutrients for the aging population, of course, vitamin A and vitamin E are for immunocompetence, no? And vitamin C also, because it plays a role in immune cell homeostasis and the differentiation and function. And the B vitamins, it helps to restore cell-mediated immunity and can improve lymphocyte maturation and growth and increase numbers of T lymphocytes. These are all actually for the immune response. So for vitamin D, during this time of pandemic, it has been very popular because everybody are actually saying, oh, you better get out and expose yourselves under the sun. That will be preventing you, of course, from COVID-19. Now, vitamin D modulates several aspects of the innate and adaptive immune system, and its deficiency is highly prevalent among elderly population. And it promotes the differentiation of monocytes to macrophages and plays a role in the process of antigen presentation. Why zinc? No, zinc is also very good because it counteracts the alteration in the immune response by enhancing both the total number of total number and function of T cells. And it's actually has been reported to increase natural killer cell activity via the enhancement of the perforin expression. Now you can see here, I just put here the life cycle of the skeleton, and you can see from age 60 years old, it's declining already, the body mass, no? So the bone density is declining from age 60 years old. Actually, you can experience that already for females during menopause, and you can see that it's really declining. That's why we really need to improve our protein requirements. So in older adults, skeletal muscles atrophy and decrease in bone mass, and the speed and force of muscle contraction is reduced. And therefore, the limb muscles are also 25 to 35 shorter and less responsive. Musculoskeletal disease is a major contributor to the global non-communicable disease burden. And I will now present to you, are we really prone to dementia? Are we really vulnerable to the COVID-19? So it has been presented that the aging population are vulnerable to dementia and to COVID-19. Let's see the nutritional status as reflected or gathered in our National Nutrition Survey. So you can see here, chronic energy deficiency is about 15% in 2019. And it has increased from the 2018 data. Of course, in 2015, wherein we have the updating national survey, it's quite high. If you compare 2015 to 2019, yes, we have actually decreased the prevalence. However, our efforts in 2018 compared to 2019 is somewhat better. And for overweight, you can see that it's actually increasing from the 2015 to 2018, and it has decreased a little bit from 2018 to 2019. So if you compare the period of measurements, however, 2015 to 2018 is a 3-year gap. And the gap for 2018 and 2019 is just 1 year. No, so you can see that if the decline here in the chronic energy deficiency is from 17.2 to 13.4, and compare this with this, somewhat it's better, no? So for the overweight, declining the prevalence from 24.7 to 22.7 in 2019, for us, yes, it's okay because we have seen almost about 2 percentage point decrease. So, however, I think there should be more efforts to really reduce this to further lower percentage. And also for obese population from 6.3 to 5.8. Now, one of the measurements for obesity is, of course, the high waist circumference. So for our population, age 60 to 69 are the most, the higher high waist circumference compared to the higher age groups, like the 80 years old and over. Why? It's just because of first the declining body weight and the muscle mass. And for elderly females, medyo mas mataas, no? It's higher as compared with our male population. And also the trend is higher. It is higher among our 60 to 69 years old, and it's declining as one grows older. And if we compare by place of residence, why do we need to extract this data? It's just because we wanted our interventions to be actually area specific. You can see that in the urban population, you can see more of this obese or overweight, no? So in the rural population, you can see lesser percentage. However, if you compare our data, 2018 to 2019, it's a good investment though, because it has declined from 7.5 to 5.9. And for elderly females, it's really very high, no? So you can see that it is also affecting the rural population, the urban population. However, we should not neglect also solving high waist circumference among our rural population. But what I'm saying here is if there are interventions, then the priority should be actually catered to the urban population. And for the highway circumference among wealth quintile, so if it is in area specific, then it should be also by socio-economic disaggregation. And it should be poured, more intervention should be poured for the rich and the richest quintile of socio-economic strata. And for the females, it's the same pattern as you have seen among males, that these are actually more prone in the rich and richest population, richest wealth quintile. Now, let me show you also, while we are talking about overweight and obesity, let me talk also about characteristics of chronic wasting. These actually mostly occur in older adults and progressive disorder. We have a chronic low-grade inflammation, and therefore the episodes of increased symptoms and metabolic stress like infections, and leads to progressive disability and poor health status, weight loss, muscle wasting, and major part of healthcare cost is really high. And therefore, if we have this, there will be higher number of hospitalizations per year, and the number of hospital stay and treatment failures will be somewhat high. So again, we are facing also a double burden of malnutrition among our elderly population. So for physical activity, we measured this using, of course, the WHO guidelines and global recommendation for physical activity. And you can see that the 80 years and over are the most physically inactive, insufficiently physically active, and starting actually from 60 years old and over. No, but if you try to target interventions, then we have to start early also, so that we will not be having this kind of figures in the super elderly age or super aging period. And if it is by sex, of course, the males are more affected than females. The females are more affected than males, no, because of the very high percentage. Almost half of our population are this elderly population are actually insufficiently physically active. And by place of residence, I think if you try to recall our percentage or the rate of overweight and obesity, it's also in the urban area. And the wealth quintile, it's the same pattern, showing us that it's actually the rich and the richest quintile are having this insufficiently physically inactive elderly population. Current smoking, which was repeatedly mentioned in the previous presentation. You can see that about 18% of our population age 60-69 are still smoking. And what is actually very glaring is even those who are 80 years old and over are still smoking, no? And by sex, of course, we have, it's somewhat evident now that the males are more smokers, having higher percentage than females. And by place of residence, baliktad, no? For the overweight and physical inactivity, the urban setting is mostly affected. But for smoking, the rural population has a higher percentage over the urban population. And also, the poor to poorest population up to the middle wealth quintile are the ones having a higher percentage of current smokers. Drinking, binge drinking. If we say binge drinking, we say that it's drinking 5 or more standard drinks in a day, no, and four for women in a row, no. So 5 for men and 4 for women, and you can see that the most population who are having binge drinking are those 60 years to 69 years old, and even it persists until the 70 to 79 years old. And what is also alarming is the 80 years old and over is still having a higher percentage of almost 30%. So by age disaggregation, we have the males higher than the females who are binge drinkers. And for for the place of residence, it is from the rural population have higher binge drinkers compared with the urban population, but it is not actually significantly different. Meaning to say, if we try to approach messages for binge drinking, then this should actually encompasses both areas, the rural and the urban areas. And also for wealth quintile, you cannot see a pattern, though you can see that almost from the poor to middle income, and that the poorest have a higher percentage, but this is not actually to discount also the higher percentage from the rich to the richest quintile, wherein we have about 41% to 49 to 50% in 2019. Elevated blood pressure among our elderly population. Now, we have done good interventions maybe because of the declining trend, no, from the 2013 to 2018, 2015 to 2018. However, if we try to look at a yearly comparison from 33.8 to 32.5, parang hindi masyado tayong satisfied ano po sa ating mga ginagawa, kasi nga it's just giving us almost 0.7 or 0.3, 1.3, no, 1.3 percentage, 0.7 percentage point from 2018 to 2019. And of course, you can see here also from the 70 to 79 years old and the 80 to 80 years old and over, it has increased, no, from 36.8 to 39.6. And if we disaggregate it by sex, then it seems that there is no significant difference between gender or sex between males and females. And from rural and urban, you can see that they have also similar prevalence. So again, interventions must be addressing both males and females, urban and rural areas. For wealth quintile disaggregation, there's no pattern also, and therefore messages and interventions must be actually a standard one. For fasting, high fasting blood sugar among our elderly population, it is higher among the 60 to 69 years old, quite decreasing though if they are already approaching the age of 70 to 79 years old and 80 years old and above. But you can see our data from 5.9% to 9.8% in from 2018 to 2019 among our elderly, among 80 years old and above is quite alarming, no? Because these are already, you know, the super seniors. And disaggregating this by residence and by sex, of course, you can see that male and female have no significant difference between the two prevalences. And also for the urban, it is higher, although in the rural population, it's also bringing us a higher percentage of about 11.9%. By wealth quintile, it is higher among our rich to richest quintile. And a lower percentage is seen among our poor to the poorest wealth quintile. For anemia prevalence, among our elderly population, that's why I presented to you the different nutrient intakes, because anemia is actually also a problem among our elderly population. So if I say all, that's the national prevalence, but if you disaggregate this by male, female, and the percentages of male and females are similar. There's no significant difference in terms of the percentages, and also between the 2019 and 2018 for females, but there is a significant decline from among the male population from 23 to 17.7%. And by place of residence, I think also rural and urban must be actually tackled. And of course, you can see a higher percentage, but very slight difference from the between urban and rural areas. And the west quintile, you can see that almost halos pareho, although you can see that the prevalence of anemia is higher, slightly higher among our poorest to the middle west quintile. And why are we having all those kinds of problems? It might be due to this. You can see that the food sources contributing to iron, the top 5 sources, no, of iron in the diet of our elderly population, you can see that it is about 28% of the requirement for iron is actually provided by rice, and you can pandesal is 5.5%, monai or the breads, no. Then you can see that 3.4 and 2.9. Now you can see the top 4 sources of iron comes from carbs, no, and we know very well it's wheat and rice. So the iron from these sources is really not very highly bioavailable to the elderly population or in any population group. It's not really very bioavailable. It's just because very low because of the phytic content of these food sources. Now, what is only important here is the pork, but it is only contributing to about 2.5% of the total iron intake for this elderly population. With regards to vitamin C sources, top 5 sources that is contributing to the vitamin C requirement, we have the saba. It's about 11.3% contributing to the vitamin C requirement. Of course, the malunggay, you can see it anywhere, you different corners, the taro leaves, and see, look at the powdered iced tea. No, it has contributed 4.1%, and the banana lakatan about 3.9%. For the vitamin A, chicken liver is the highest contributor to the requirement of vitamin A among this elderly population. Maybe because of its, the cost is somewhat lower compared to the other vitamin A rich foods. So we also have pork liver, pork lean, the fortified milk, and chicken egg. And for calcium, again, you can see that rice is the main source. It's 17.4%. I'm very happy that they are also about 7.2 and 3.5% are actually drinking milk, and that's contributing to about 7% of their requirement and 3.5% of the requirement for this milk high calcium fortified milk. And the dried anchovy about 3.1%, and the chicken white meat about 2.7%. So in summary, overweight and obesity, as well as android type of obesity, slightly declined in 2019. However, that was not showing a very significant decline. And anemia also declined in 2019, and this is to some extent notable among males and those belonging to the poorest and poor quintile. Physical inactivity also slightly declined, but as I told you in my presentation, this did not bring us a very significant decline. There is somewhat an increase, a slight increase in chronic energy deficiency percentage from 2018 to 2019. And binge drinking among currently drinking elderly also is slightly increased. And this is evident to some extent also in females. And elevated blood pressure and high fasting blood sugar rates were high among our elderly population. 1 in every 3 elderly had elevated blood pressure, and 13.7 had high fasting blood sugar. Proportion of current smokers did not change. So, as you can see, if you relate the nutritional status, the lifestyle behavior of our aging population with the previous presentations, the COVID-19 and the dementia, you can already assess whether are we really prone to this kind of disorders or to this kind of illness. It's really glaring that our elderly population have poor nutritional status. And because of that, the risk of hospitalization increases when food intake is limited by illness or injury. Hospitalization itself often worsens nutritional status, and loss of lean body mass delays recovery and impedes rehabilitation, as well as the risk of dying increases when food intake is limited by illness and injury. How I wish that the nutrition concepts or principles or nutritional management be also integrated in the management of the diseases in the elderly population. In the master training, Doctor, as I have seen in the presentation of Dr. De La Vega, how I wish and how I dream that nutritionists will be also included in the training so that there will be a holistic approach in terms of solving dementia and other illnesses among our elderly population. Now, what can be done to win the battle against this cardiometabolic risk? I say cardiometabolic risk, it's just because diabetes, hypertension, the lifestyle behavior are actually the cardiometabolic risk. So we must allot sustainable investments on promotion activities in the local and national levels. Aggressive campaigns with massive impact on public awareness should be done. It has actually, I'm very, very happy. I have seen actually the different papers, and they are especially the paper of Dr. De La Vega, that there is really already steps forward on awareness campaigns. And we have to redesign the home, work, community, and leisure environments to encourage physical activities. Now, this is a very popular key actions by WHO. We better eat healthy, be physically active, avoid excessive weight gain, check blood glucose if in doubt, and follow medical advice. And of course, this can be done by the government as well as different sectors, no? In partnership with the private sectors or industries. So this is actually to ensure healthy environments, better data, and better diagnosis and treatment. So I also would like to see that there should be a close-knit relationship between community and the hospital. This pertains to the referral of cases when the patient or the elderly individual is confined in the hospital. There should be a very close referral to the community in order not to actually have this elderly individual, the illness of this the elderly population become severe, no? Or go back and revisit the hospital again. So this data, I just like to tell you that it was collected by our 650 field researchers nationwide, and I'd like to thank them for their efforts. Kahit na po isang bahay ang nandoon sa isang mountain, they have to reach out just to gather the data kung yung bahay na yon ay isang sample ng aming survey. So maraming salamat po, and the FNRI always say thank you with a heart to all our partners. Maraming salamat po.
Thank you very much, Dr. Agdepa. That was indeed a very informative and educational presentation telling us what are the energy and micronutrient requirements for the aging population. And we took note that protein is very much important so that we as elders must be able to take a large number of vitamins A, B, C, and D, and zinc, no? And we should also observe not to be obese because this is prevalent in ages 60 and above. And therefore, we should take care of our chronic wasting. So among the nutritional food that has been suggested is the intake of iron, vitamin E, and calcium. I think Dr. De La Vega is still around, and she's taking note that nutritionists will be part of those who are going to be trained for our dementia training. And so we also took note that there are these metabolic stress that we should look into. And therefore, we thank you for this presentation. And now, as we like to get as much as question and answer, we'd like to turn over the floor to Dr. Catublas and Dr. Torres, please, for Q&A.
Thank you very much. Thank you very much, and congratulations to Dr. Imelda Agdepa for the excellent presentation. It is indeed very important to support the nutritional requirements of our aging population, especially at this time of pandemic, as they are among the most vulnerable group of the population. So we just have, in the interest of time, we just have few questions here from Dr. De La Vega. A question to Dr. Agdepa: where are the FNRI data published?
Actually, we have published some of our data in Nutrients Journal, Journal of Nutrition, and of course, we also have Journal of Philippine Science, no? And some other publications are, these are actually published in Scopus Index already. So we are actually aiming all the publications to be in Scopus Index journals.
Thank you, ma'am.
And for those topics, for those topics that you cannot see in the if you search in the journal, then all our presentations for the National Nutrition Surveys and for the completed researches of FNRI, this is actually available already in our website. And the results or the collected data from our National Nutrition Survey can be accessed public use as a public use file, and you can actually do an in-depth analysis of the data. This is to maximize the utilization of our data, because this is actually the investment of our government. Thank you.
Thank you, ma'am. Thank you, ma'am. That's very well noted. For another question from Mr. Lawrence Flores, what is the counterpart of the MIND diet or the Mediterranean DASH intervention for neurodegenerative delay of the Western countries, which is linked to preventing Alzheimer, dementia, that can be adapted here in our country, especially for those aging population in the poor rural area?
FNRI, for that matter, did not yet have any research on the Mediterranean diet and its effect on dementia. I think that's one to be considered later.
I see, ma'am. Allow me now, ma'am, to please ask the last question. What protein, in terms of the protein source, because we know that this is very important. So what protein source is most recommended for our older population, considering the low metabolic rate among elders? And if there is a specific type of protein source that is most absorbed or have better absorption, particularly among this elder population, ma'am?
We know very well that the animal sources are the best source of protein. However, this contains also, of course, the fat, no, the saturated fat. So it's really a combination or a variety of foods wherein plant sources like your like the beans, no, and other protein source like your milk are actually the best sources of protein also. We don't prevent the elderly population to be eating more meat, but try to actually get the lean meat in order for you to have sources of not only protein, but also iron. And also the fortified milk as sources of protein.
All right.
And the
Thank you
legumes.
very Okay, ma'am. Thank you very much, Dr. De La Vega, for graciously sharing your valuable insights. So let me now turn over the floor. Oh, sorry. Thank you very much, Dr. Agdepa. So let me now turn over the floor back to Dr. Nuna Almansor.
Okay, thank you very much, Dr. Catublas and Dr. Torres for our Q&A. And thank you once again, Dr. Agdeba, for that presentation. So at this point, we may now call on again on Dr. Maria Belinda Buenafe to virtually present to us the Certificate of Appreciation. Dr. Buenafe is the Dean of the Institute of Nursing of the Far Eastern University. Ma'am, Dr. Buenafe, please.
Okay, thank you. Thank you, Dr. Agdepa, for your insights into this important topic on nutritional needs of the elderly. You emphasize on the importance of understanding how dietary needs change as we age due to physiological changes and encourage the high intake of protein and other key nutrients. With that, on behalf of everybody here, we would like to award the Certificate of Appreciation to our third speaker, and please allow me to read the citation. Metro Manila Health Research and Development Consortium, in cooperation with Far Eastern University and Our Lady of Fatima University, presents this Certificate of Appreciation to Dr. Imelda Angeles Agdepa for exhibiting exemplary knowledge and competence as speaker in the webinar, The Road to Super Seniors, The Science of Aging, Session 2, with the theme, It's Earlier Than You Think, But It's Never Too Late, given this 19th day of September 2020. Again, we would like to thank you, Dr. Agdepa. Marami pong salamat.
Salamat po, ma'am. Thank you so much.
Okay, thank you very much, Dr. Buenafe. Now we are moving on and nearing to our closing ceremonies. And again, we would like to thank our distinguished panel of speakers, Dr. Cruz, Dr. De La Vega, and Dr. Agdepa. And so now, to give us our closing remarks, may we call on the Director for Research, Development, and Innovation Center of Our Lady of Fatima University. Ladies and gentlemen, let us welcome Dr. Michael Joseph Dino for his closing remarks. Sir?
Okay, thank you very much, Dr. Nuna, and a pleasant day to our attendees and viewers of our webinar. I am pleased to experience and take part in the success of our second to the 3 webinar series on Super Seniors. The Science of Aging, presented by the Metro Manila Health Research and Development Consortium in collaboration with the Far Eastern University, Our Lady of Fatima University, and leading organizations in research, education, and health. As a researcher working on various projects for seniors at the Our Lady of Fatima University, I am deeply honored to hear our discussants focusing on several trends, issues, and challenges facing our elderly cohort in their achievement of quality life and healthy lifestyle. Donald Reid once mentioned, to forget the elderly is to ignore the wisdom of the years. As a country, we are deeply recognizing the valuable contributions of our seniors. It has been predicted that seniors will continue to comprise a substantial percentage of our population, most especially in developing countries like us, and our continued efforts to offer them the best life possible highlight our deeply rooted Filipino characteristic of respect and love for our elderly. We take pride in our values. In most countries, aging is feared. I sincerely hope that the world will change its mindset to consider aging as a life achievement, not only because of the discounts and preferences given to our senior cohort, but for their leadership, life lessons, and outstanding exemplars. The number of wrinkles must be considered as battle marks. So in behalf of the organizers and team behind this timely and relevant webinar, I would like to thank our distinguished speakers for sharing their time and expertise. First is Dr. Grace T. Cruz, the Director Population Institute of the College of Social Science and Philosophy from the University of the Philippines, Diliman, for sharing a study on COVID-19 and the Filipino older people, giving us a message that scholars and scientists in aging studies are proactive and resilient even during these challenging times. To Dr. Shelly Ann de la Vega, the Director, Institute of Aging of the National Institutes of Health of the University of the Philippines, Manila, for her talk on community-based care on dementia, making us realize that we, regardless of our health background, can offer our share in caring for our seniors. And finally, Dr. Imelda Angeles Adgepa, the Chief SRS NAMD Science 2 and OIC of the Office of the Director of the DOST Food and Nutrition Research Institute, on her talk on nutritional data on Filipino aging population, emphasizing on the healthy and well-balanced diet is indeed still important until seniorhood. Kudos and a virtual round of applause to our speakers, MC, moderators, and committees behind this endeavor. To our researchers, may we continue to pursue knowledge in this relevant field as we make this world a better place for our beloved super seniors. So thank you. Keep safe, healthy, and happy.
Thank you, Dr. Dino. Before we finally say, can you please share the screen as we invite our audience to our next webinar on September 26th. Okay? So this is, you're all invited once again for September 26th for our third and last series of webinar for this symposium. Okay? So this is your host, Dr. Nuna E. Almanzor, as an engineer, Executive Director of the Adamson Center for Research and Development. Thank you, everyone. Thank you, Dr. Hazel. Thank you, Dr. Torres and Dr. Venus, Dr. Dino. Before that, can we flash on the screen the link for our post-test and evaluation? All participants are requested to please accomplish this through your Google form. And as we sign off, may I request the panelists and the working and organizing committee members to stay for our photo opportunities. Thank you very much and good afternoon to all.